It's a more patient-centred way of working, where clinical staff are trained to work with the client as well as a whole network too. Their family, friends and the people around them. And it's a genuine spirit of partnership. And the way we make change at a deeper level so that all the people affected can be helped together and the whole community can collaborate with the team to get a longer lasting recovery. The outcome this new way of working is demonstrated in teams and trials around the world have been tremendous. I've heard stories from our service users about the difference it's made to their lives, and you will hear many today, and this has been truly moving and inspiring to listen to. So this new approach is obviously making a real difference on the ground. Our staff love it, our service users are really appreciative of it, and I'm really proud that alongside 5 other trusts that NELT has been a pioneer in bringing it into the NHS. So we're now on a new phase in the journey in which our own trust as well as a range of others across the country are now utilising it as part of the community mental health transformation. And I spent a lot of time talking with Russell in his supervision about that. It's truly transformational. And it promises to be an informative and exciting day and another landmark in the forward journey we're making together to genuinely improve the quality of care that we provide in our mental health services. And I think one of my reflections, I'm not a psychiatrist, I'm a radiologist, is that we are a species, we are a group who are storytelling. If you look back in our history, it's about having the voice and telling our story. And I think this is exactly what open dialogue does. It plays to that, it puts the person at the centre and really allows them to tell their story, which I think is so, so powerful.
And this interest in open dialogue has been very much something that has been national. So we've had, I remember first being called into NHS England about 10 years ago and being asked to tell us about this open dialogue thing we've been hearing about in various countries around the world. And I started dialogue in NHS at that time, and there's been a lot of exploration and interest. We obviously started the ODDESSI trial, which was funded as one of the largest model of care mental health trials in the world. It's the biggest grant that has been received by mental health, a piece of research in this country in recent years. And while that's been ongoing, there's been a lot of interest in starting to incorporate major aspects of it into the transformation, as Caroline mentioned.
After 2.5 difficult years of the pandemic, we have never been more reminded of the importance of the social ties which bind us and give our lives meaning. We all know that the way to find the best outcomes for the people we help is to include their families, friends, communities and wherever we possibly can. For many years, we've aspired to this principle of care in the NHS. But I know there are times when our services have not always found the methods with which to achieve this. However, in Finland, they did find a way to do it really well, and they called it open dialogue. The kind, compassionate and humble way in which they approach the care and inclusion of those families affected by mental health problems is now a beacon for the future of how we should be developing our services. The World Health Organization cited it as international best practice just last year, and there's been growing understanding and capacity around this approach in the UK over the last 8 years. The care in our next decade will be trauma-informed, address inequalities, emphasise the person at the centre of care and be inclusive of family and community. The principles laid out in the open dialogue approach realise that vision we have for mental health care. I know it's something that many of our service users and carers have been asking us to invest in. We know what a difference this is going to make to our people and the people we care for. Making change happen is not easy, particularly in these turbulent, trying times, which we've all lived through recently. It takes patience, perseverance and determination. I know all of you have that as you are here making the future happen. And I wish you the very best as you work to bring hope and compassion to those who need it most. From the bottom of my heart, thank you.
So we know that family and network make a big difference to people's outcomes. There's actually, not quoted here, but there's actually a study, the ESOPS trial, some of you will know it. It was a trial into EIP services a number of years ago. It was a huge trial at the time, almost as big as the ODDESSI trial is now. And they found some outcomes which were applicable, generalisable to all services. One of the outcomes they found is that whenever you involve people's families and networks in their care, it actually reduces the suicide rate by up to 90%. So there's a huge impact of involving families in people's care. There's been numerous RCTs over the years about family therapy and the difference that makes to people's long-term outcomes, how it reduces hospitalisation, it reduces people's long-term relapse rate as well. Also saves money because it stops people coming in and staying in the system for very long. The other evidence, of course, has come from the international WHO studies. And what they found, is quite strikingly in the 60s, they did a massive study across the world. They looked at mental health services in the West, so in Western Europe and the States, and they compared that to developing countries. And what they found is that people who had diagnosis of schizophrenia actually had better outcomes and recoveries long-term than people in the West. Now this was a big head scratcher, so they did it again in the 70s and 80s across 10 countries. And they looked at that difference and they found the same thing was happening again. In developing countries, people had better outcomes. And they did it again in the 2000s. And they did it with thousands of service users, a massive piece of work by the WHO. And again, they found that actually in the developing countries, people are having better outcomes. Now, there are many reasons for this, and we can debate them all day. And it's been debated, over all of these decades, why this is the case. My family originally from Bangladesh, and if somebody has a breakdown there, a mental health episode, usually the family come together, and usually they're around in the same neighbourhood. They start to come together and have a talk about what's led to this. They start to tell their stories, and that is very likely to be one of the reasons why there's something going on in terms of different outcomes. People's first port of call is to actually bring community together around the crisis. Services might step in later, or sometimes not at all. So there's something about that, something about involvement of families that seems to make a real difference. So now what the Finns did is that they incorporated that into the front line of their services. They actually used to have some of the worst outcomes in the world. So in northern Finland, they used to have some of the highest relapse rates, some of the highest suicide rates. And what that enabled them to do was to actually shut down and restart their services. So they restarted their services with a series of experiments, one of which was called Open Dialogue. And what they did there is they trained all of their staff in learning systemic relational ways of working. So every doctor, every nurse, every social worker, every OT, every peer worker, everybody in the team was trained to work relationally, they were trained to work with systems and families. Now it's not an easy thing to do, because actually it is not the path of least resistance. You're inviting more emotional turmoil potentially in the early stage. But to be prepared to do that and to allow some of the underlying issues to come out takes some real training and some real resilience. So that's where the Open Dialogue training comes in, and that's what they started doing in Finland. Train all their staff in using every crisis as an opportunity to bring people together and work with the community and the network. And because of that, they describe every single person in the network as a potentially equal partner in the process. And that's not a simple thing to get across really, having a partnership relationship with network members, i.e. family, friends, service users, etc. That's a very different kind of culture really, because we're used to them providing us with information, or us giving them information, but not so much in terms of genuine collaboration, in terms of, okay, you're as responsible for this as me, you know about as much about this as I do. The outcomes that they found in northern Finland when they do this was pretty stratospheric really. If you look at the first column there, Open Dialogue, compared to treatment as usual, they did a naturalistic follow-up of all of their patients compared to what it used to be before they had Open Dialogue. And what they found was that there was a significant reduction in people's symptoms and people's experiences compared to what they used to be. They also found that there was a very, very low relapse rate. That's a big figure to focus on. I'll come back to that. There are less people claiming benefits in the end. There's less use of medication. There's less hospital bed days. And yet, there's far more people who are getting better in the long term and not coming back into services. Only 70% of people were bouncing back into their services. So a small minority were coming back. The vast majority, about 74% altogether, had left services for good and never came back. Now that is a lot higher than most everywhere else. In most other services, it's actually the minority. And they're looking at people who had acute psychosis, so major crisis, not sort of every presentation, but they looked at the higher end of complexity. And what they found is that actually the vast majority had some Open Dialogue for a couple of months, had left and then never came back again. Compared to other services around the world where the vast majority do come back. And then after a 5-year follow-up, they found 86% again had left services and not come back. Now, if you look at this outcome data, around most countries, and it's kind of, if you draw a graph of most countries' outcomes in terms of relapse rates is around here, and then Northern Finland is over here. So it's a complete outlier, which is why a number of other countries around the world have taken it up. So the first thing is that what Open Dialogue fundamentally is about creating a space where the services' narrative and story, rather than our own, can start to evolve. So people can start to form their own understanding of what's happened to them, what led them here, and what is the underlying kind of story in their life. And it's about staff learning skills to create a space for as many voices as possible to be heard. If they have a task, it is to allow as many people as possible to share their story, to use their voice. And we have techniques that we teach people to do that, because often service users and networks will come into the meeting without much of a voice, without much of an ability or desire to speak. So we're trying to use some very subtle ways of getting the dialogue out, and beginning to get them to start to do that with each other. So that's really key, and that's what most of the training is really about. That forming what we call polyphony, multiple voices coming apart from people, getting them to relate to each other, and getting them to start to form their own story. That means that clinicians have to be skilled at getting them to talk, rather than us to talk. And that very different approach means that we sometimes have to be able to tolerate some uncertainty. So without jumping in there early on by saying, okay, this is what you've got, this is what we need to do next, we need to be able to restrain ourselves a bit and create space where they can start to articulate that themselves. And that does take a bit of training, because we're quite used to solving things for people. But often when we do that, we remove the possibility for them to say what they think is happening and trying to understand it themselves. I remember when I started learning Open Dialogue from some of these guys a number of years, 10 or more years ago now, I remember realising how powerful my voice was. So when we'd be sitting with families and networks, realising that if I made a statement now, how it would actually stop any further dialogue, because, well, the consultant says that. Okay, well then that must be all there is to it. So, but if we step back from that and allow them to speak, and encourage them to speak more, we get to a stage where they can start piecing together their own understanding of what's happening, and their own way out. And it's not rocket science really. Once we teach them to use their own resources, and once they start to forge their own understandings, in the end they realise they don't need us as much, and so they don't remain dependent on services as much in the long term, and they can continue using their own resources as they move forward. And that is what we hope will eventually reduce relapse rate dependence on service and community. Because of that, because we're giving them the space, because we're giving them the opportunity to start to understand the treatment, they can then start leading on what they want. So they might be thinking about CBT, they might be thinking of some psychology, they might be thinking about medication. And it's all the better because it's come from them. And I've found since doing Open Dialogue, I would say about 19 out of 20 times when I've prescribed, it has been because they have asked for it. And because of that, it's been a lot more useful, it's been a lot more taken on board, and we work together in terms of how long we stay on it, and that has helped because they've led that process. Of course, when there are risks and other things, then you have to act as you normally do. But in the meantime, which is the majority of the case, we try to create that space. Essentially what we're saying is that, and the ethos within Open Dialogue is very much that we can learn something from everybody. So the clinician is coming into the room with a spirit of, we're here to learn from you, as much as the other way around. And I just remember my first ever Open Dialogue meeting, we were sitting there, and the family saying to me, look, this is what's happening, you're the consultant, you tell me what's the problem, and what we should do. And so I realised, well, how is this Open Dialogue thing going to work now? So I turned to them and I said, well, actually, you know what, you have the experience of what you're describing, and you have it all together, and I've never had that experience. So in many respects, you're the expert in what's happening here, and perhaps we can hear more from you and learn more from you. And then they paused for a minute, they looked at each other, okay, and then they started to speak. And they carried on speaking from meeting after meeting over a period of years. And that really changed the trajectory of their journey from somebody who'd been in services for 40 years. She ended up coming out after about 2 or 3 years of having a regular Open Dialogue. She was able to use that space, but we had to do some work to recalibrate it, to help them get the idea that actually, you know what, we're here to learn from you. You have a lot of the resources, a lot of the understanding, a lot of the capacity within you, and that's how we started that process.
Hi, I'm Huma Bedell. I have been using or getting help with Open Dialogue for over a year now, and I have to say it's in the beginning, knowing how anxious I was and wondering whether this would help me or whether it was pointless in doing this, I still went ahead and sort of pushed through and thought, okay, well, someone like me who needs the help, went through with it. And I can honestly say it's one of the best things that I've had. I mean, I've always said this, you can have there are people in your life to talk to. You have your spouse, partner, your kids, friends, but they will always have a different perspective because they are who they are and they know you in that way. But to have two complete strangers who eventually you kind of come to know in a way, it's like having friends, but without the judgment and without the advice. They're just there to listen to you and show you parts of you, the good parts of you, the positive parts of you that you yourself failed to see. Thank you so much, because if it wasn't for you guys, I don't think I'd actually be able to even get on with my day, or even my week sometimes. Again, a little bit emotional. For someone like me who, for a really long time, couldn't even get out of bed, wasn't even doing the daily usual things with my kids. I missed out on a lot of time with my family, my husband and my kids. I, because of them, have that back now. And I couldn't be more grateful. Yeah, thank you so much. And like I said, this is something that a lot of us need and don't realise we need it. A lot of us bottle things up and try and tend to deal with things on our own, but it's okay, because there are a lot of people out there like that who think and feel the same way and are hurt in different ways, and can get the help. Basically, to know that there is the help out there, that we can get the help out there. They make a difference, and I hope they do. I'm sure they realise it, but, you know, and I'm sure it will be nice for them to hear from someone like me to know how much they make a difference in my life and how grateful I am, because I wouldn't be the me today. So thank you.
I have been given the opportunity to tell my story, which I felt was very helpful for me. I have experienced a very different approach to my needs, and I have felt like I've been building trusting relationships through the experience with the team, whilst also realising that they too have experienced difficulties at times. I have noticed the difference between the two different approaches when I was admitted to hospital. I found it cathartic to go over and understand my situation and what brought me to the psychiatric services in the first place. I also found it helpful and beneficial to gain insight into why I was feeling so angry and distressed. And that's helped me to gain more clarity.
I trained for 4 years as a family therapist. I trained for 3 years as an open dialogue trainer. And when I got together with Russell, as Russell's already said, the NHS, why is it sort of a mind of its own? Anyway, the NHS are not going to fund long trainings. We have to do something that is possible. And so we developed within months. Within 5 months, we had a 1-year training course, and it's been running since 2014. It's 4 residential weeks over 10 months, quite intensive. Currently, our venue, we've just moved there to Fitzwilliam College, Cambridge, so our students are very happy to say they're attending the University of Cambridge. We are accredited by the Association for Family Therapy and Systemic Practice at foundation level, and we also have accreditation with London South Bank University, a postgraduate and graduate certificate. So what do our students learn? Okay. First of all, really important, mental health distress is an expression of something that hasn't found words. That's a really underlying sort of idea. that either they have found words and they haven't been listened to, or they haven't found words. So what do they learn? They learn the principles, and they do lots of practice of open dialogue. We encourage them to start practicing immediately after the first week of our residential. They learn about working in teams and how important that is, how important the relationships are between the practitioners as well as the relationships with the people who are coming to us. And it really, I think, important to us is social inequality and how this impacts on people's mental health. You know, the things that are very difficult to control around poverty, education. We try and embed that as well in our practice.
And today is really kind of a little celebration for me as an academic. It's a pivotal moment. We started work developing a master's in open dialogue. Peer-supported open dialogue together with LSBU. When I started working with open dialogue 20 years ago, it felt like it was small, it maybe wasn't going anywhere. We struggled, there was a lot of criticism of it. At that time, there was probably just a handful of articles citing open dialogue. A little Google scholar search yesterday told me that there's over 2,000 articles now that refer to cite open dialogue, and it's a growing field. And next year we have a special issue coming out in Frontiers in Psychology, focusing specifically on open dialogue in global perspective. Early on, people said, this is northern Finland, maybe it works there, but it doesn't work the rest of the world. The New York City Parachute Project, what's happening now in England, shows no, it's fundamentally human, and therefore it helps people all over the world. So we have teams in China, we have teams in Singapore, we have teams in Japan, we have teams in South America, we have teams in the Czech Republic, and all over the world. Over 30 countries now where it's being practiced. And so there is an increasing global demand for both trainers and research. Open dialogue was one of the few approaches that was recommended by the World Health Organization. So we're at that point where it's not untraditional, it's not counterculture, it's not anti-psychiatry. No, it's really good psychiatry as recognized by the World Health Organization. So as part of that, we're doing something that I think is really exciting. We're developing the first master's program in peer-supported open dialogue, essentially the first master in open dialogue in the world. We're working with London South Bank University, we've been working with since 2016. Again, that first year is so important. Most of you are familiar with the first year, but we can also take a second year, which is a PG dip. And you can jump off that if you want, or you can continue for another year and do a master's. But if we're going to spread this over the NHS, we need more trainers. And when we have more qualified trainers, then we can have more qualified trainees. We can have more qualified practitioners. If we're going to spread this across the NHS, there's a huge need. And so by establishing a master's, that really gives us a basis where we can expand and meet the demands that are going to be there. Just remember how much of a difference one voice can make. The one voice of Russell 10 years ago, Val 20 years ago, that one voice really does sometimes help the person. That one light really does bring darkness. And I think what Nelft is doing, what you're doing here, is that light for so many people, not only in England, but around the world. You are that light for so many people that are in darkness.
Hi, I'm Louise Jessup. I'm a lived experienced person, I would say. I'm in Europe, it's on my screen. Just a couple of reflections really. I'm open dialogue trained as well. I'm passionate about this thing. When I'm unwell, not dealing with stuff very well, I don't want anyone to do it for me. The point of a worker is that they are walking alongside me. It's a very difficult path in my life. And I don't want anyone to do it for me, to tell me what to do, but I want that space to enable me to work through stuff so that I can find my own way through, however hard it is. And sometimes we have to face real difficulty and go through it, however hard it is, in order to be able to cope in the future. The other thing I would say about recovery is in the last 18 months, I have come off all psychiatric medication after 40 years. It's been the fight of my life. I've been through dreadful withdrawal. They've overruled my diagnosis, they said that I was never mentally ill, never manic depressive bipolar, whatever you want to call it. Severe trauma when I was 17, 18 with the family. And if I talk about the word recovery, that suggests that I'm going to recover something that was. No, I am emerging into someone new. I don't know who I am coming off medication. I've been sedated and good as a lot for 40 years with horrendous medication, side effects of the lot. Now I'm off it all. My brain's gone bananas as it's trying to cope with no sedation. I'm becoming me, Louise, the person maybe I should have been and found 40 years ago. It's terrible that at 64, I'm only to find that out now.
Hello, I'm Annie Jeffrey, and I came to mental health looking for a new way of working that might help and support my eldest son, Tom. Sadly, he took his own life before Open Dialogue started, so we never actually had a chance to do Open Dialogue, but I firmly believe that if we'd had that, he would probably be here today. And his voice is always with me. I trained in the first year of the training, which is quite a few years ago, and I work as a carer within the Open Dialogue team.
Hi, I'm Alex. I've only been working as a peer worker for about the last year with Wolf and Forest and then a little bit with Dialogue First just recently. But before that, I've received Open Dialogue for about 6.5 years now. And I'm at that point now, I had 6.5 years of treatment as usual before that as well. So I've been in treatment since I was 18, and I've got a good idea of the difference of being under treatment as usual for years, being in section, going through things like that, and then having started receiving Open Dialogue in section since and things like that, but also how the treatment was different. And then so for the last year, I've been working as a peer worker with Open Dialogue and doing training at the moment. Working as a peer is something I've been saying for years, but going back quite a few years. I wish I could go back and talk to myself when I was 18. I first was hospitalised and first coming to having a manic episode, having no clue what was going on. And I guess the closest is talking to someone like a peer worker who's actually been through something like that. I can feel that in, especially when I join networks with someone maybe with bipolar disorder having a manic episode. I can talk to them about it in a way that I don't think many other people could. Like, someone's been restrained and injected and stuff. It's pretty hard to sympathise with that in a real way, and she's been through it as well. And I do really see the value of being a peer worker. I would have liked to go back and talk to myself, and probably the closest I can get is talking to people that are going through it now. I feel like I get so much purpose and meaning from doing this work.
So the acronym at first, ODDESSI stands for Open Dialogue, Development and Evaluation of a Social Network Intervention for Severe Mental Illness. It's a randomised trial, the point of which being that you hope that if there's a difference in outcomes between one group and another group, that is because of the intervention that was given. It's trying to make that the only difference between the kind of intervention and control group. And the control arm, which is treatment as usual, which again varies in different trusts and for different people. And then you follow both groups up for quite a long time. In this study it's 2 years for the main trial. And compare outcomes between groups and hope to attribute an outcome to the intervention from that design. So in trials it's important to specify before you do the trial what the primary outcome is. So in this, the primary outcome is time to relapse. So from that measure we use time to relapse, but we also have a lot of other interesting things like days in recovery or days unwell. The kind of main trial, the clinical cost effectiveness will be by March 2024. The last data that we'll collect for that will be September 2023, so that will be the earliest.
And so I went on that first week of training, I felt like I dropped down the rabbit hole. And I thought, what is this thing? Everyone here, and I found myself really questioning my own professional identity during that week, to have a sort of mirror held up to how people experienced much of the treatment as usual services. And then thinking, oh gosh, am I part of the problem? And so that was a hard week to go through. And then we got into actually trying it in practice with families that we were helping. And the feedback we got from the service users and their families was incredible. And for me, that was the moment where it clicked, is that actually I don't even need to wait and see research evidence. The practice-based evidence is so strong. And I was asked as a clinical director to take the lead for the Trust on the Community Mental Health Transformation, which is this centrally planned document that had come out from NHS England, Community Mental Health Framework, NHS Long-Term Plan. Here's these ideals that we have to, this vision that we have to try and enact. And as I sat and read through these documents, it's something I thought, actually, they're looking for open dialogue. The other things that they're talking about within this framework of it being person-centred, developing on people's strengths, being culturally sensitive, addressing the inequalities of access, working closely with our communities, working in partnership with other organisations, and being inclusive of family and social network. They've painted the vision there. And that's where the open dialogue, I think, is a serendipitous moment right now. That there is this ask of us to do things differently within mental health services. And I think that there's been a huge amount of groundwork done to get us to that point, which we must pay homage to respect to, that the service users and carers have constantly had to raise their voices against a system that is not often wanting to hear the feedback. So I really do take my hat off to all those people who've had to struggle for so long to get that message across. But you have got to tell it, that has started to shift, that central messaging, that central strategy of work. Now we need to deliver the message of this is the vehicle by which we can start to see that vision actually happen.